Hello, and welcome to the Princeton Spine and Joint Center podcast. My name is Scott Curtis. I am the Director of Sports Medicine here for the practice. I just finished a great conversation with a sports physical therapist named Nick Cifelli. Nick works at Progression Physical Therapy here in Princeton and also at the training room down in South Jersey. The focus of today's topic was ACL injuries. We had a great conversation about both primary and secondary prevention for ACL tears from a rehab perspective. We talked about what the ACL is and how it can be injured. And what are the steps to not only diagnosing an ACL tear, but managing it both surgically and non-surgically. So if you've ever experienced an ACL injury or you're a parent of a child who has, I encourage you to take a listen to this podcast. Thanks, and hope you enjoy it. Hello, and welcome to the Princeton Spine and Joint Center podcast. My name is Scott Curtis. I'm the Director of Sports Medicine here for the practice. I'd like to welcome all of our listeners and viewers to this episode. And today I'm joined by Nick Cifelli, a sports physical therapist here working at Progression Physical Therapy in Princeton and the training room down in South Jersey. Nick and I are going to be talking about ACL physical therapy protocols, both for prevention and for treatment. Nick, welcome to the show, and thanks for joining us.
Thanks for having me.
Yeah, and so before we kind of talk about ACL injuries and how not only to prevent them, but also to treat them through therapy, tell us a little bit about yourself and how you got into sports physical therapy.
All right. Yep. So I was born and raised in Ewing, New Jersey. It's a couple of minutes down the road. Always into sports, baseball, soccer, all the other sports in the backyard. I got injured my freshman year of high school, had physical therapy for a broken ankle. That kind of got me into the PT realm of things.
Sure.
Did a observation that summer, went on to TCNJ for health and exercise science, where I played baseball there throughout my 4 years.
Nice.
After that, I went to Thomas Jefferson for my doctorate in physical therapy degree.
Cool.
And then here I am.
Very well trained, it sounds like,
Yep.
and you clearly have a passion for sports and sports injuries. We're going to be talking today about the ACL. What exactly is the ACL in the knee? I mean, we always hear about it in terms of football players on ESPN. This guy blew out his ACL, is done for the season. What is the ACL, and why is it such an important part of our body?
It's one of 4 ligaments of the knee. It's a dynamic stabilizer of the knee. So when we're running, cutting, making those tight maneuvers, the ACL is kind of protecting and stabilizing the knee. If there's any kind of strength deficits, when you make a wrong cut, you're not able to control it. That's when you hear the ACL tear.
Yeah, and you mentioned it's one of the dynamic stabilizers. The way I always think of the ACL, it's one of the big ligaments in the knee that hold it together, essentially. You have two ligaments on the outside that stabilize the 2 bones. Those are your LCL, your lateral collateral ligament, and your medial collateral ligament. But on the inside part of the knee, you have 2 big rubber bands or ligaments that cross each other, the anterior and posterior cruciate ligaments. And the ACL is one of the biggest and most important ligaments, truly, from a musculoskeletal standpoint in your body. And when it's injured, it could impact you significantly. So tell me about some of the patients that you see in physical therapy.
So my full-time position down in South Jersey, I see predominantly athletes there. And probably of those athletes, probably at least 50 to 75% are ACL.
Okay.
ACL patients, more so post-op.
Okay.
So I have a good background on the post-op rehabilitation and how they should be progressing through their therapy.
Okay.
Of all ages, 14, 13, the youngest patient with the ACL, post-op ACL, and as old as 50, 55.
Sure. So usually we see this in active individuals, and we'll often suspect ACL injuries in individuals who will have acute knee problems, acute knee pain. What are some of the ways that people injure their ACL? What's kind of that classic thing that you hear?
So the more agility sports, soccer, basketball, football, they run downfield, they make a cut a non-contact injury is most of the time when you're going to suffer an ACL injury.
Yeah, I mean that's classic. Not only when we take the board exams, but in practice, it's a non-contact injury, right? If it's in basketball, they're landing, coming up from a rebound, or they're turning, on the soccer field, or they're twisting. These are all kind of those buzzwords that we think of when a patient comes and sees me. I'll often get the patient, they're coming in, they need to be seen right away because they were playing, soccer yesterday. They felt a pop in their knee, then it got really swollen. They can't put pressure on it. And that's the first thing I think of in a young individual. And there's a lot of different risk factors for ACL injuries. The biggest risk factor is actually gender. Females tend to have a much higher rate of ACL injuries than men do. And there's a lot of different reasons for that. Certainly the sports, basketball, soccer, the cutting sports, but also previous knee injuries as well. So when I get a patient and I'm thinking ACL, I kind of run down this checklist. How do you go about examining for an ACL injury?
So if I have a patient coming in, they just got injured, say a week ago, whatever it is, they come in, I palpate, see if there's any kind of joint tenderness around the knee joint itself. Then there's, that key question, did you hear a pop?
Yeah.
Did you hear a pop? That's a good indication that there might be some kind of ligamentous issue.
Sure.
And then I run through a series of special tests specifically designed for the ACL, checking for laxity in that knee joint.
Yep.
And I'm going to roll in or out the other ligaments and menisci also.
Sure. Yeah, because unfortunately, when you kind of lose that big ligament, some other subsequent injuries could happen. In fact, in medical school, they teach us about the terrible triad or the unhappy triad, where you have not only the ACL tear, but you tear the medial meniscus, and you also tear the MCL as well. And that's obviously not a very good sign. To me, it's no different than any other musculoskeletal complaint. You take a very thorough history, you kind of hear the story, and then you do the inspection, range of motion check. You look for any kind of obvious swelling, bruising, any kind of deformity that might result when the ligament's not there holding it together, and then you palpate and you do your special tests, looking for laxity, doing that anterior and posterior draw sign, the Lockmans. All of these are super important, and if you pay close attention while watching a game, let's say an NFL game or a soccer game, you're going to see those maneuvers done right away, because once you develop swelling and you develop guarding, it's really hard to get that kind of Lockman or that anterior draw sign. And then after that, if there's a high suspicion for an ACL, I'll take the time to figure out what the appropriate tests are. X-rays can show subtle hints in terms of different types of fracture patterns, but you can't really see the ACL on an X-ray. ACL is best viewed on, obviously, an MRI, so I'll often order that when I'm suspicious of it. But that's when an actual injury occurs. Do you ever see patients who may have risk factors for ACL that come to you for prevention of ACL issues?
Oh, yes, absolutely. Probably every teenage female that comes in with any kind of knee pain.
Yeah.
I have them, I go through basic functional exam. I have them squat. This goes for males as well. Have them squat. I'm looking at the angle of their hip going down towards their knees. Most of the times, high risk factor if the hips are outside of the knees and the knees are kind of, getting close to each other.
Why is that a risk factor?
Just you're not developing that strong core and glute to control that knee, and with the cutting mechanism of the injury, that's when it occurs.
Yeah. I mean, there's certainly that plays a huge role. Anatomical alignment and how we're kind of standing and running puts a lot of pressure on the knees and the hips, and if you're not in absolute anatomical alignment, it can just put a little bit extra pressure on it. One of the other things that I always look for is landing mechanics, in particular for basketball players, for soccer players who are going up for headers. How do you test for landing mechanics, and what do you advise patients in terms of injury prevention?
Yeah, so the few different jumping exams, tests that I go through, I can have them just drop off 10, 12-inch box, land on 2 feet, see how they land on one leg, see how they land, how they can control their body. And then I go through a series of single leg jump tests.
Okay.
Just a single leg jump, comparing side to side, and for assessment of their movement, how they're controlling the knee. A triple jump,
Okay.
crossover jump. So you put a line down on the ground. You're going to cross over 3 times. See how you can control your body that way.
Okay.
Those are just a few different jump tests that I use on a day-to-day basis.
And if you find something that's abnormal or that you're concerned about, are there any interventions that you could do as a therapist to kind of correct those?
Yeah, so I had to figure out why they can't control their body or their knee, and then I break down. I go, I check their core, check their glute strength, hamstring, quad strength.
Yeah.
There's a lot of research out there saying different numbers of what your quad strength should be compared to the other side, and rate of tearing the ACL.
Yeah, and that's a big thing, is quad to hamstring flexibility and strength. I always say, look, we're focusing on the knee. That's true, but we have to look at you as the whole body, right? So even though we're concerned about your knee for whatever reason, we'll look at your back, we'll look at your core, we'll look at your posture, we'll look at everything. Because patients get very confused. Well, why are you checking, my back if it's my knee? You're a whole body. You're not 2 knees and 2 hips. You're a whole unit, and we have to treat you as such, and we have to examine you as such as well. Tell me a little bit more about some of the approaches in terms of strength training for neuromuscular control for ACL prevention.
Okay. Well, first I would get them on the table, make sure that they can activate their core and their glutes in a non-weight bearing position.
Okay.
Before I get them up on their feet.
Okay.
If they're not able to activate the glutes core on the table, then I'm not going to expect them to be able to
Sure.
on a weight bearing.
You got to work from the ground up.
Exactly. And I go through a series of weight bearing activation drills to activate these key muscles, and then more from a neuromuscular standpoint, proprioception wise, I check their balance, single leg balance with their eyes closed on different kind of surfaces. So I might have them stand on one leg on a foam pad or a dyna disc, just kind of throw off their balance a little bit.
It's hard to do for anybody.
Yep.
Yeah.
Yeah, and then I kind of see how they respond to that.
And then after you work on those kind of things and you make your assessment, do you give them kind of a structured home exercise program, or do you work with them one-on-one in the clinic? What's your approach in terms of prevention?
So I'm definitely going to give them exercises to do at home for those key deficits. It's mostly the glute med. That's one of the hip muscles that we want to strengthen up. That's going to be a nice muscle to control the knee. So I might give them a series of glute exercises on the mat, as an example.
Okay.
Then I have them come in, and then maybe my next visit I check their limb symmetry.
Okay.
That's going to play a big part. So leg press, maybe like a isolated quad tests, and jumping, like the series of jumping. So I like for them to be at least 90% from side to side.
Okay. That could be a little bit difficult when you have a soccer player, for example, where they're more dominant with one foot. Do you find that that soccer players are a little bit more unique in that there's going to be just an inherent imbalance with side to side?
Yeah. So I mean, if they are right foot, left foot dominant, actually, if they're planning with the opposite foot, sometimes they're even more stable on that side.
Yeah, that's true.
Yeah. So you got to really take both limbs individually and kind of see if there's a significant difference.
Yeah. And soccer players are so unique with not only their cutting ability, but the fact that they're planting so much and that they're using and quite frankly abusing some of these ligaments so much at such a young age and for a long period of time that in fact FIFA has developed kind of this protocol for injury prevention, the FIFA 11. I don't know if you're familiar with that. Basically, they came up with a series of very easy exercises to do that don't require any equipment, that soccer players are encouraged even at a young age to do, things like single leg lift and core exercises like planking, in addition to their regular warm-up. And that actually scientifically has shown to reduce some injuries, in particular ACL tearing. So that's been implemented at the higher levels, at the collegiate levels, and at least at the professional level in most cases. So soccer players, anytime I hear a soccer player with a knee injury, especially an acute injury, ACL is one of the first things I think of. And so ACL in soccer players, but also basketball players too. Not only professionals and individuals who are at a higher level, but more so the amateurs, the people who haven't really played in a long period of time. They decide to go pick up and try to get in shape. They come down wrong or they plant, they feel that pop, they're in trouble. So do you take basketball players into any kind of different exercises or different landing mechanics?
Yeah, the exercises I give each patient in the beginning, they might be the same, and then I get more specific into the type of movements that they're doing, regardless of the sport. So basketball players, they're gonna need to move a little bit different than a soccer player to a football player, and all the other sports.
Yeah, I think sport-specific physical therapy, yes, we want to correct, obviously, any underlying deficiency, look at any risk factors, but I think the sport-specific stuff is super important, especially for the high-level athletes, the high-end athletes, because they've already corrected a lot of times some of the deficiencies. Now they have to apply it to what they love to do and hopefully prevent things from happening. Unfortunately, primary prevention, which is preventing something from ever happening, doesn't always work, and sometimes we have to treat the ACL injuries. So let's talk a little bit now about what happens after the patient tears his or her ACL. At this point, I would have had the MRI. It shows, let's say, a complete tear of the ACL, and maybe we'll just say it's an isolated ACL tear and that there's no other injuries. In my mind, an ACL injury can be treated non-operatively through intensive physical therapy, but more often than not with higher level athletes, especially at a younger age who have a whole lifetime of athletic career ahead of them, I'll send them to a sport-specific surgeon to do an ACL reconstruction. So from my question to you is, how is your approach different for non-operative ACL tears versus operative ACL tears?
Well, the first phase, we want to reduce the swelling, regardless if it's non-op or operative. Then we're going to regain the strength, and you're going to check for the deficits as well. So, quad, hamstring, glute strength before or after surgery, and then depending on what they want to do, they might not need to get the surgery. Like you said, like the younger athletes that have their whole life ahead of them, they still want to play sports, they're probably going to have to get the surgical intervention. I just as an example, last year I had a woman in her 60s tear her ACL skiing. The doctor did not want to do surgery.
Sure.
She had goals of hiking and skiing.
Yep.
Rehabbed her for 4 to 6 months, and I just got an email last week that she went back to the same mountain that she tore her ACL, and she was able to ski.
That's awesome.
Maybe not as aggressively as she once did, but without surgery, she was able to get back on
in a couple of months. Yeah, 4 months or so. Usually, there's everybody always asks the time frame. The decision whether to do surgery or not really needs to be individualized. I'm a firm believer of that. Now, I'm biased. I'm not a surgeon. But this is one of those things that I have absolutely no problem sending to a surgeon for, because if you don't do the surgery, there are risks and benefits. If you do the surgery, there are risks and benefits. One of the big questions is timing of things. If I don't do the surgery, how long will it take for me to get back to skiing? Maybe not as aggressively as you said, but usually it's like 4 months or so. And I'm just throwing that number out there because it makes sense. As opposed to if you do the surgery, it's going to take longer for that graft to kind of adhere to where you're putting it in. And that might be a more prolonged recovery, usually anywhere between 6 and 12 months. I usually say 9 months to kind of split the difference. We have to kind of, when counseling patients about, whether or not an operation is indicated, talk about realistic expectations and, what happens if you don't do the surgery versus what happens if you do the surgery, in terms of things like developing arthritis later in life or risk of re-tearing the ACL graft if you were to go play, this or that sport. So the one thing I kind of want to give, at least to our listeners and viewers, is one, not every ACL tear absolutely has to have surgery. And two, the decision whether or not to have surgery really needs to be individualized. That's kind of what I try to preach to the patients. And, it's really just a conversation that we have. In terms of postoperative surgery, are there kind of protocols and restrictions that the surgeons will often talk to you about afterwards?
Yeah, so I see post-op ACLs from numerous of surgeons down in South Jersey. They all have their own way of thinking.
Sure.
So they have different protocols, but overall they're basically the same. You want to reduce swelling, regain your motion, especially extension. So extending your knee, get the quad strength back, so you're able to do a straight leg raise without any kind of lag. Get you out of the brace so you're walking normal again, and then at that point just trying to maximize your strength and stability. And there's research out there regarding different types of machines or techniques that will give the patient the most benefit to get back.
Are there kind of any specialized equipment that you use if they're postoperative?
Yeah, so blood flow restriction is it's been around for a little while, but I think it's starting to take off now.
Yeah.
So we're occluding the blood flow actually, but there's a lot of research backing up that it's going to create some hypertrophy in the muscle cell, so some swelling in the muscle cell that's going to help with strength gains later down the road.
Yeah, we've on this podcast we've talked about blood flow restriction and some of the benefits behind it, and we mentioned how that the majority of the research behind BFR physical therapy is actually with the postoperative patients. And there's a lot of really positive things specifically for ACL with blood flow restriction that I think is really, really, like you said, it's been around, but it's really more cutting edge now than ever. I think primarily because there's a lot of athletes who are just using it for training purposes, so it's becoming a little bit more mainstream. But I'm really encouraged by some of the data behind it for postoperative, but also limb-specific injuries. I think that's really cool stuff that we do, or I should say you do, that I just write for. So in terms of ACL surgery, just to kind of educate some of the patients, when the ACL tears, you can't just sew the two pieces back together. It doesn't work that way because there's not a great blood flow, so it won't heal and it will just kind of be a useless surgery to do. So what happens is you reconstruct the graft, and you could do it in a few different ways. There's one way in which you take the own tissue from the patient, usually either the hamstring or the patellar tendon, and you basically are recreating a ACL using your own tissue, usually a tendon. The other way is to use a cadaver tendon or a cadaver ligament, and you're implanting that into yourself. And there's pros and cons to both. If you talk to different surgeons, you're going to get different opinions about it. But those are the two general ways to go about doing a surgery for the ACL. Is there a difference in terms of rehab, whether you have the cadaver versus your own tissue as the graft?
Yeah, so let's say patella graft, taking the patella tendon, so on the front of the knee. There's research backing up that is the strongest graft that you can have, the least rate of re-tearing. Yeah. The rehab might be a little bit longer, especially even with the hamstring graft as well. Yeah. Compared to a cadaver graft, it's not your tissue, so you don't have to heal the graft site as well. There's risks for rejection since it's not your tissue. You might recover faster, but there's a higher rate of re-tearing the cadaver.
Yeah, and the decision what to do is really a discussion to be done between the orthopedic surgeon and the patient. Like you said, the benefits of your own tissue is that it's your own tissue. You are not going to reject it because it's yours. But the problem is that it's essentially two surgeries. You have to harvest the graft, either from the patella or the hamstring, and then you have to let that heal. And then you have the ACL surgery as well. As opposed to the cadaver, you're just undergoing the one surgery, but it's not your tissue. And so because it's not your tissue, it does take some time, and there's a possibility that you're going to reject it. But from my standpoint, I would think that the physical therapy would not be so much different for the ACL, but if you have that additional surgery to harvest the site, that's going to be an area you have to rehab as well. Is that appropriate to say?
Yeah. So let's take the graft. Yeah. They might develop some more patellofemoral pain syndrome. You have to work a little bit more on the patella tendon later on in the recovery. And the hamstring graft, let's say you're not able to activate your hamstring for about 12 weeks. So we can't do hamstring strengthening for I think 10 to 12 weeks.
Okay. Does that delay things, or if, let's say, the surgeon were to take the hamstring from the contralateral side, would the person who has the ipsilateral side or the same side hamstring, would they be delayed in terms of physical therapy progression because he can't activate those hamstrings, or would it be about the same?
If it's the contralateral
Yeah.
leg, so if it's contralateral leg, then both sides are involved. So that's a little bit more complicated.
Okay.
But whenever there's a delay in strengthening, there will be a little bit behind. But I haven't seen
Nothing major.
Yeah.
Okay.
Nothing major.
Yeah, that's good to know. So, what's the expected outcome? Or let's say the patient undergoes either surgery, the cadaver or the allograft, or the patella or the hamstring. What's kind of the expected time course in terms of physical therapy?
Yeah. So the first 4 to 6 weeks, regaining that motion, quad strength, get some more weight bearing properties going, mini squats.
Okay.
Different exercises like that. Then 6 to 12, you want to maximize strength. At that 12-week mark, the graft is at its strongest. Then you're able to push it a little bit more.
Okay.
So I go through a series of LSI, so limb symmetry index testing. So like I said before, the leg press, the isolated quad strength, and I go through a heel tap. So just dynamic stability, how they're able to control the knee and hip on an 8-inch box.
Okay.
If they're able to get 80% from one side versus the other, we begin lightweight acceptance activities.
Okay.
So that's maybe dropping off a box and landing, working on landing mechanics, and then progressing to jumping. And we like to go through a series of single leg jumping before running, because if you're not able to produce a certain amount on one leg versus the other, there's no point in running, because it's not going to look the greatest.
Happen.
So as soon as they're able to get 80-85% single leg jump one side versus the other, and it looks clean, it looks good, well controlled, then we'll go through a series of running. So that could be anywhere between 3.5 to 6 months.
Okay.
So 3.5 to 6 months, we start patients running.
Okay. Yeah, and that's the variability in terms of expected time to recovery. When I tell patients, well, it's anywhere between 6 and 12 months, that's a pretty big range, So some patients will say, well, how do I get to that 6-month mark? Because, I got to get back for that. What's the difference between a prolonged recovery versus not? It's really hard to predict, isn't it? Or are there some patients that you could say that person's going to be more 6 months, or that person's going to take a little bit longer?
Research backing up to it, I say no less than 9 months.
Okay.
Any time before 9 months, you're at a significant increase to re-tear your ACL.
Yeah. And the research does back that up, but there are some people who make a full recovery within 6 or 7 months for whatever reason. Is there any kind of difference to your approach if there's a secondary injury, such as a meniscus tear as well, or an MCL sprain, or do you kind of approach it the exact same way?
Well, if there's a meniscus tear, I guess it depends on whether they're going to scope.
Let's say that the surgeon fixes everything all at once.
So they're going to repair.
That's usually what happens. Since they're in there, they're going to fix the meniscus, or they'll take a look around and clean things up.
Yeah.
If they have that kind of additional surgical intervention, does your approach change at all, or is it kind of the same thing?
Yeah. So we have to respect the meniscus repair. So they're going to be less weight bearing to begin therapy. They'll probably be in the brace.
Yeah.
Locked into extension for a little bit longer, and then there's some range of motion restrictions. We might be limited to only 90 degrees for the first 6 weeks, and then a gradual progression from there. So it is a little bit slower.
Yeah, and that could be frustrating for patients. Now, let's say you have the patient who tears the ACL, surgery is scheduled. Is there benefit to kind of what I call prehab, intervening earlier with rehab before the surgery?
Yeah, absolutely. Yeah, the patients that I have for pre-op, we get their range of motion back to full, get their strength up as much as we can.
Yeah.
I find that they have a better outcome coming back to me after their surgery.
And most studies would show the same kind of thing, that doing some range of motion exercises, strengthening exercises before the surgery is definitely beneficial. The damage, unfortunately, is already done, so you're not really hurting yourself by doing exercises, especially in a controlled environment, supervised by somebody like yourself. So I'm, even though I'm not a surgeon and I see an ACL tear, I'll get you into physical therapy right away in conjunction with having a consultation with an orthopedic surgeon. Now, what happens, let's say you have the patient, the soccer star who has the ACL, comes back next year, is now playing, doesn't have any kind of injury, but wants to prevent it from happening, as secondary prevention. What do you kind of advise that person? And is there a way that physical therapy might be beneficial for secondary prevention of ACL tears?
Yeah, so if you have one tear, you're at an increased rate to re-tear it, unfortunately, but there's ways to prevent it or maximize your chance not to re-tear it. Coming in to see a physical therapist, we're able to re-examine you, see how you're moving, see your strength, any kind of limitations, and then address those limitations and deficits.
Yeah. And do you focus just on the knee that was injured in the first place? Or do you look at the other side as well?
I'm going to look at both, because I think the research out there says if you tore one, you're at increased risk of tearing the other.
Yeah. And that's what I always get concerned about. And you just have to counsel the patients that, yes, your right side is what you tore. That's the one you're constantly favoring, but that's the one you're constantly exercising and strengthening. The left side also wants some attention too. And if you develop this imbalance, you're just a setup for developing a left ACL tear. Now you've lost 2 seasons, right? The right side first and then the left. So we got to, it's secondary prevention for one knee, but primary prevention for the other. The approach doesn't necessarily change, but it's something that we need to be cognizant of, work on landing mechanics, work on, the quad to hamstring ratio. And I think it's super, super important for patients to understand that just because you've recovered from an ACL doesn't mean that you are bulletproof going forward. It's really, really important that you continue to do the work after everything is all said and done to prevent it from happening again. I think that we've really hit a lot of points in terms of what the ACL is, how do we do primary prevention, what occurs during primary prevention, what happens postoperatively and preoperatively, what happens with secondary prevention. Is there anything else from a physical therapy standpoint that you think is important for our listeners and viewers to hear?
Yeah, so if you're in for therapy post-op ACL, you get through the progressions, running, jumping, you're probably going to be discharged around 5-6 months, but that's not when your rehab stops.
Correct.
It's very important, 6 to 9 to 12 weeks, that you're continuing with either a strength coach or athletic trainer, someone at your school or wherever you are, to continue progressing these different deficits and just maximizing your strength and quality of movement.
Yeah. I always tell patients, whether it's an acute issue or a chronic issue, the most important part of physical therapy to me is actually after physical therapy is completed and you're discharged, because it's on you to continue with the homework, continue with the home exercises to prevent things from happening again. Because once, I see a lot of patients who feel fantastic after they're done with therapy. So what do? They don't do the home exercises because they're cured, right? 3 months afterwards, all their muscles have atrophied. They're back to the same exact position that they were in before the therapy started. With the ACL, if you're discharged, you're not fully there yet. You have to continue doing the work. Otherwise, you're not going to get back to where you were functionally and from a health standpoint as well. Anything else that you think might be helpful for the listeners or viewers?
Yeah, if you're an athlete or a parent of an athlete and you have no injury, but you feel like you have some of these risk factors, you can always come in and see a physical therapist, have them just check out your movement, just do a little movement assessment to see if you're at increased risk, and then give you the appropriate set of activities to perform so you can just strengthen and maximize the stability of your whole body.
Yeah, I think a little bit of prevention is way better than a whole lot of treatment. Well said. All right. Well, thank you so much to our listeners and to our viewers. Really appreciate you taking the time to take a little bit of interest in education about the ACL, and I hope you enjoyed it. Thank you.